Because we'll call the speakers for the discussion, please. Dr. Tawfiq Bassam, Professor Mustafa Kemal Erol, Dr. Tahir Hassan, and Dr. Olivier. Can we have the microphone here working? It's not working. No, okay. So if anybody has any question, we will start. Professor Roberto Ferrari, he's the co-chairman of the session, and he can start the discussion and the questions. He's our privileged, distinguished speaker, invited speaker to our meeting.
If I have to ask a question, I would like to start with the last talk. And I fully agree that particularly, hear me? I fully agree that particularly in hypertension we are not successful in convincing our patients to take the drugs, which are available, effective and cheap. So it's not a question of money. In many countries where I'm working, for instance, drugs are completely free, so it's not a question of cost. It's just a question of conviction. You mentioned that digital can help, but you didn't exactly told me how can help. For instance, I myself, that I am a computer virgin, I made an application with the Faculty of Mathematics, not for hypertension, but for self-calculating the risk chart for cardiovascular disease. This was an application provided to the population of the city where I'm working and living, the city of Ferrara. And once that we had this application, which by the way you can go and look at it, and we tried to make it as attractive as possible using designers and so on, then we started to do some publicity through newspaper, through the football team. You know, every football match there was a big screen saying, please go and do your self-assessment for cardiovascular disease from the University of Ferrara and so on. A lot of enthusiasm for the first 2 or 3 months. Now, every time that the football team, which is in the superior, in the highest level, is playing, still there is all of this. Still, we are going to newspaper, schools, and so on. But it seems to me that the interest for the digital stuff, like all these watches for running and so on, does not last very long. And we are dealing with chronic disease, which could be a solution.
This is a very tricky question.
We need a short answer.
And this will be a short answer, yes. First of all, we are all different. If I had to convince each of you to stop smoking, for instance, I would use for each of you different arguments. And I will use my second job, which is about digital marketing. And for this, we have what we call multi-channel marketing. The fact that today in your digital life, you are surrounded by ads, and some channels are more efficient for you or for another one. So, first of all, to reach the first time the persons, yes, we have some tools. The second one, about long-term engagement, for sure those solutions might not last for 30 years like for drugs. So we need to renew the concept. The Fitbit and all the activity trackers, we all know those wristbands. We use them for 2 weeks, and then now I know that I'm walking 9,000 steps a day, I don't care about it anymore. Why? Because this device gives me figures, meaningless figures. If I have an app that gives me my blood pressure, it doesn't make any sense to me. If I convert those complex figures, systolic, I don't even know how to spell it for the patient. If we convert it into something gamified, and we use those techniques used by the video game industry, those guys managed to hook people for years. We just need to have new stakeholders in the world of medicine to learn from them, I think.
Thank you very much indeed. Do we have any question from the audience or comment? Yes.
My question on the renal denervation and simplicity, the sham worked very well, and there is like very good reduction in blood pressure. And the recent Lancet trial, the sham did not work at all. So what is your comment on this?
Prof. Mustafa.
In previous studies, simplicity HTN3, there was no. I couldn't understand. You asking this sham procedure didn't work in between studies?
Bring it closer. Closer.
Yes. Yes. In simplicity 3, in sham control study, sham control groups, blood pressure decreases significantly, but in last studies not. You asked to say, I understand. In simplicity 3, maybe the drug adherence not check. Drug adherence may be a factor for this because the last studies, drug adherence was detected by urine or blood test, but before the first studies, not drug adherence assessed. Maybe a factor, but fully I don't know.
Yeah, it's very good that in the new European Society of Hypertension, European Society of Cardiology guidelines, they have mentioned very clearly that recommendation is 3 for any interventional management for patients with hypertension, unless it is really going for trials. Randomized, controlled trials. So until now, I mean, not everybody is in favor of having any interventional management for the patients with resistant hypertension. Do you agree with that?
Now, at the moment, I agree. But second generation studies injected a new optimism. And it's very early to say, recommend routine use the renal denervation. But after the long-term follow-up, if this decrease persisted the 2 or 3 years, I think new guidelines will change the recommendation again.
Dr. Tawfiq?
Just, may I have a comment, please?
Yes.
I think not only the European, even the American guidelines, even the Canadians, up to now, 2018, they do not recommend renal denervation to be used in resistant hypertension, only for research purposes.
Yes.
The reason behind that is because we had a problem before. Many patients were put for renal denervation, they didn't have resistant hypertension at all. Now we start to know, so we want to avoid repeating the mistake again.
Yeah, I agree with you, because now there is Michael Baum presentation with the study he did for renal denervation. It was done renal denervation for patients who does not have resistant hypertension, and they did not start on medication. They are off medication, naive for medication, mild to moderate hypertension, and he did renal denervation and he showed improvement. But this is continued to be randomized controlled trials more than for clinical practice. Professor Roberto?
Well, I would like to make a general comment, because renal denervation ablation of atrial fibrillation and so on, to me, a really bad example on how you should destroy a possible good idea. We learned from your presentation that some of these trials were not conducted well. We heard that some of the renal denervation were not done in the 4 areas as they should. And very often people, particularly when there is a device and so on, they are pushed to do, they like to do it, they like to come out of the cath lab and saying, I've made it, and they do it badly. And we construct clinical trial with, at the end, bad results simply because the procedure was not made perfectly well. And that will frozen the future research, because nowadays nobody is doing renal denervation because we are all convinced that it's not good enough to reduce the blood pressure in really resistant people. It's the same with atrial fibrillation, with ablation of atrial fibrillation. Do we have a sham-operated trial? No. And we just accept it. And we all know that 30 to 40% of the patients is coming back and so on. We all know that some of the ablation are not done properly, are not done with the right technology and so on. So my message is, if you participate in a trial, it's not just to participate. It's not just to get the money for participation to the trial. It's part of medicine. To participate in a trial is a duty that we do have as a doctor, but we have to do it properly. Because if we don't do it properly, we might, and it's the same that's happened with stem cells. Everybody injected stem cells without knowing what to do. The end results, we are not even considering anymore stem cells because the study was not done properly. And in this respect, I have to say that the drug companies, probably because they have to fulfill several points in order to have their drugs approved, at least they are trying to do the best possible clinical trial, but not the device company. And that is a big problem.
Thank you. We have time for one question, if anybody has. I have one question to Dr. Tahir, really, and this is always in our clinical practice. Patients with hypertension and coronary artery disease. Most of the time, these patients, they are more of elderly. They are not very young. And in elderly patients, we have diastolic blood pressure slightly low, systolic slightly high. When you will use medication, it might decrease both. So what will be your advice, comment on that issue? Do you want to come here, Dr. Tahir? No? You can use this one if you want.
This is a good question. Actually, patients with coronary artery disease, they depend on their perfusion on the diastolic time. They perfuse in diastole. And it's important things not to lower it very aggressively, and at the same time don't make it short by using medication that accelerate the heart rate. And we will see that patients in whom you lower the blood pressure aggressively, or you give them medication that increase their heart rate, they might end up in extending their infarction, or if you take the beta blockers out suddenly. And they are different from those who are revascularized. Patients who are revascularized, they have a different response to that. So it is important, the first thing to do is to slow the heart rate, make the blood pressure recently decreased, and at the same time keep an eye on anything that can reduce perfusions. And by doing that, patients will get benefit. Thank you.
Thank you very much indeed. Before we'll end the session, we'd like to give the Professor Mustafa Kemal Erol, and we'll have photo together. Where is the photo man? Disappearing as usual.
Professor Takrim Al-Hassan.
Prof. Tahir Hassan.